There's a concept in anatomy and physiology, and that's extrapolated into pharmacology that I've always wanted to address, and that's the idea of adrenergic versus cholinergic receptors. I'm going to see if I can't condense it into two different videos. So I'm going to go ahead and do adrenergic receptors in this video, and then we'll do cholinergics in another one. Okay, adrenergic receptors, you have what's called alpha and beta adrenergic receptors, and you're going to have alpha 1, alpha 2, and then beta 1 and beta 2. Okay, adrenergic receptors respond to the neurotransmitters epinephrine and norepinephrine. Okay, so there's another word that we're going to introduce also called an agonist and an antagonist. An agonist, by definition, induces the natural response of the receptor. An antagonist will do the opposite response of the receptor. So if we go to alpha 1 receptors are located very abundantly in our blood vessels, and they naturally, when they bind to epi and norepinephrine, cause your blood vessels to constrict. So vasoconstriction is the word. So if you have a drug that is an alpha 1 agonist, it's basically going to cause your blood vessels to constrict. That's things like phenylephrine, pseudoephedrine that treat like nasal congestion and things like that. For an alpha 1 antagonist, it's going to do the opposite of that. So instead of causing vasoconstriction, we're going to dilate. Okay, that's things like prazosin, tamsulosin, which is also called Flomax. We used it to treat hypertension and benign prostatic hyperplasia, which is an enlarged prostate. It kind of helps open up those blood vessels in the prostate so that the patient can urinate more. So that's your alpha 1s. Your alpha 2 receptors are a little bit different. They are located in blood vessels, similar to alpha 1s, but they're also located very heavily in the brainstem, and they have a natural inhibitory activity in the brain. So they're going to bind to norepinephrine especially, and then prevent this further secretion of this neurotransmitter. An alpha 2 agonist, by definition, will be very inhibitory. This is a drug like clonidine is an alpha 2 agonist. Clonidine will be used to treat a little bit of hypertension sometimes, but also a lot of ADD. Kind of helps with this natural depressant activity in the brain. For the antagonist, we don't really have any alpha 2 antagonists that they use in medicine. It's mostly used in veterinary medicine. There is a drug called mirtazapine, which is a tricyclic antidepressant that they can use though. For your beta receptors, you have beta 1 and beta 2. Okay, beta 1 receptors are located in your heart and your kidney and some other areas. The natural activity of beta 1 is a positive chronotropic and a positive inotropic effect. So it's going to increase heart rate, increase contractility. Chronotrope is timing, inotrope is force of contraction. So a beta 1 agonist will increase contractility, increase rate. That's the drug. That's a beta 1 agonist is called dobutamine. Is a really good example. They'll use that for heart failure. A beta 1 antagonist will do the opposite. It'll decrease force of contraction, decrease heart rate. This is all your all. So like metoprolol, propranolol, labetalol, atenolol. These are all your beta blockers they'll use for high blood pressure. Beta 2 receptors, they're located very, very heavily in your smooth muscle, especially in your airways. Okay, so it's going to cause naturally bronchodilation. So a beta 2 agonist increases bronchodilation. This is drugs like albuterol or terbutaline, which are used like inhalers and stuff for asthma and certain aspects of COPD. Now, we don't really use any beta 2 antagonists. There's none that are FDA approved. That would naturally it would cause bronchoconstriction, which is what we don't want, but they are used in research. So those are your alpha and beta adrenergic receptors. I hope I can help just a little bit, taking a very difficult concept and making it a little bit easier.